Good morning and welcome to this, the 18th meeting of the Joint Select Committee on Social Services and Public Administration. This is the third public hearing pursuant to our inquiry on the state of mental health services and facilities in Trinidad and Tobago. I would like to welcome the officials from the Ministry of Health who are here with us this morning, the Ministry of Education, the Children's Authority of Trinidad and Tobago, Trinidad and Tobago Association of Psychologists, the Association of Psychiatrists of Trinidad and Tobago. This morning, we are here to focus on the mental health services and facilities provided for children and adolescents in Trinidad and Tobago. The reason for focusing on children this morning is that this particular, our committee has been looking at mental health issues in Trinidad and Tobago. We have undertaken site visits to institutions, and we have found that there is something or some questions to be answered with respect to the facilities available for children who are experiencing mental illness. And by that I mean, I will refer to, under the laws of Trinidad and Tobago, Chapter 4601, it defines a child to mean a person under the age of 18 years. There was a view by committee members upon our inquiry and our investigations that we need to delve further into the facilities available for the mental care of children, citizens of Trinidad and Tobago under the age of 18. I would like to welcome again our loyal listeners on Parliament Radio, our viewers on the Parliament channel, the members of the public who follow us on the various social media sites that are the platforms available for them to communicate with us. And I want to welcome all the officials who are here with us this morning. We have a very full house. We have a number of agencies interested in this particular problem. So it appears that there is a problem with respect to the care for children who are experiencing mental illness. And for members of the public who have been following the work of our committee, we were also looking at an issue of school violence and bullying amongst the children in the under 18 group. And these are issues which are now culminating in our investigation on how it is that children and the children of Trinidad and Tobago are coping with the various stresses of being children and what kind of treatment facilities are available by the state to handle mental illnesses of children. I will, at this point, ask the following representatives to offer brief introductions because we would like to give all participants an opportunity to inform the committee on what their views are on the way forward with respect to the mental health of the children of our republic. Yes. So I will ask the following officials to offer brief opening remarks. The Permanent Secretary, a familiar face to this committee, of the Ministry of Health first. Permanent Secretary, Ministry of Education second. The Director, Children's Authority of Trinidad and Tobago third. The President, Trinidad and Tobago Association of Psychologists fourth. A representative of the Association of Psychiatrists of Trinidad and Tobago. I would ask you to offer brief opening remarks. You introduce yourself at the same time. And as we proceed in the questioning, members who are going to respond will introduce themselves at that point in time. Once you are done, members of the committee will introduce ourselves, and we will proceed with the inquiry. So, Permanent Secretary, Ministry of Health.
Good morning, Chairman and members. I'm Richard Madre, Permanent Secretary, Ministry of Health. Thank you for the opportunity to appear before you to discuss this important issue of child and adolescent mental health services. At present, the Ministry of Health, through our regional health authorities, has the mandate to deliver mental health services to the population. This is achieved through the following: 3 national services. These are located at the St. Anne's Psychiatric Hospital, the Substance Abuse Prevention and Treatment Center, and the Arimas Psychosocial Rehabilitation Center. 3 acute inpatient psychiatric units and wards, 2 extended care centers, 3 child and adolescent outpatient clinics, 27 adult outpatient clinics. As the Ministry of Health seeks to continue the improvement of mental health services, a new model of care for mental health is being developed that is client-centered and promotes recovery. This model will consider evidence-based protocols and practices for mental health, such as early intervention, respect for human rights, and the integration of mental health into the general healthcare system. Our ministry recognizes the complexities and vulnerabilities of the child and adolescent population, and the Ministry of Health seeks to provide comprehensive, integrated, and responsive mental health care with a special emphasis on rehabilitation and recovery in community-based settings rather than institutionalization, ultimately.
Thank you, Permanent Secretary, Ministry of Education.
Good morning, Chairman and members. The Ministry of Education is pleased to be invited and to contribute at this meeting of the Joint Select Committee, with a special focus on the state of mental health services and facilities for children and adolescents in Trinidad and Tobago. The establishment of the Student Support Services Division within the Ministry of Education was aimed primarily at providing ongoing support for all students to maximize their full learning potential and to develop holistically within the school setting. In fulfillment of this objective, the Ministry continues to develop internal synergies and collaborations. In this regard, the divisions of school supervision and student support services work collaboratively to implement systems of referrals from the classroom to professional internal staff, and where necessary, directed referral from our ministry out to specialist care by the relevant health authority or institutions. The divisions of educational planning, education facilities planning and procurement, and curriculum planning cooperate along with student support services to plan and improve accessibility for students diagnosed with special needs. The Ministry of Education also works collaboratively with internal partners and agencies to establish protocols for effective client service delivery. These include the Ministry of Gender and Child Affairs, the Children's Authority, and the Child Guidance Clinic at the Ministry of Health. In providing an equitable, quality, and accessible education system for all learners, the Ministry is guided by our national laws, policies, and several pieces of legislation. We also look at international conventions, which include, inter alia, the 1989 United Nations Convention on the Rights of the Child, the Convention on the Rights of Persons with Disabilities. We identify with and is fully cognizant of the challenges of attaining education for all as outlined in the United Nations SDGs. We specifically refer to Goal 3, which speaks to ensuring health and well-being, as well as Goal 4, which looks at including and ensuring inclusive, quality, and equitable quality education and promotion of lifelong learning opportunities for all. As we endeavor to expand our inclusive education system at every level, the Ministry continues to develop, contextualize, and implement initiatives that meet national objectives, but seek to develop our students as 21st century citizens and learners within an ever-evolving and continuously changing learning and working environment. In this regard, particular emphasis is placed on nation building, self-actualization, spirituality, mental and physical health, happiness, and emotional well-being.
Interrupt.
Yes?
The remarks are supposed to be brief at the opening.
Right. Well, we're finished. I'm finished.
Very well. Thank you very much.
So we look forward to
you
the
will,
morning's
You will be given an opportunity to elaborate as the hearing proceeds.
Right.
Yeah.
You intervene at the right time.
Very well. Thank you very much. May I ask the Director of the Children's Authority to offer brief opening remarks to us?
Good morning, Chairman and members of the committee. My name is Safi Noel, Director of the Children's Authority. Chairman, please allow me to introduce Mr. Hanif Benjamin, our chairman, who is actually the one that is called to bring the remarks on behalf of the authority. Sure.
Good morning, Mr. Chairman and members of the committee, and thank you for allowing us the opportunity to delineate this morning's most important topic as it relates to our children, more so because in less than a week we will be looking at the World Children Universal Children's Day. And I think this is fitting that we have this conversation in relation to our children and mental health. For far too long, there has been a stigma regarding mental health, and often families are ostracized. For far too long, our children have been labeled as bad child, delinquent, or beyond control. And unfortunately, our response has been to those different labels. We have been looking at mental health and what is going on in Trinidad and Tobago, and we have seen in various reports where 1 in 4 persons are living with mental illness. There's also a report of our children living with mental problems in our nation's school, home, and communities. Unfortunately, we also see our inability to adequately manage and treat the high number of children living with said mental illnesses. The article also notes that there is 1 mental hospital, the St. Anne's Psychiatric Unit, and 31 outpatient facilities. Notwithstanding that, however, Mr. Chairman, we see inpatient care woefully lacking for our children. I beg the question then for us to delineate here, what about our children? Since the Children's Authority of Trinidad and Tobago have been delivering services to children and their family, we have noted a significant number of children presenting with mental health illnesses. It is truly worrying for our staff as they see children without place to go. So while the authority is working closely with other entities, we welcome the opportunity to have this conversation with the committees and other colleagues this morning.
Thank you very much. Thank you very much. Yes, we will continue the conversation. The opening remarks are supposed to be brief, 2-3 minutes. So because the opening remark is just like the opening over. It's not the full 10 overs you have in limited cricket, right? Just the first few balls of the over. Okay. Could I ask the president of the Trinidad and Tobago Association of Psychologists to offer us brief remarks as well?
Good morning, everyone. Dr. Margaret Naked-Chatur, President, Clinical and Educational Psychologist. We believe that many children with mental health needs are not receiving the required professional help. And although the likelihood of receiving care increases with clinical severity, seriously emotionally disturbed children are yet to receive any kind of mental health care unless from an outside provider. One of the key players we believe in the provision of mental health services is the education sector. And for many children in this country, this continues to be the sole source of care, as the general healthcare system plays a relatively minor role in service provision for children. In our proposals today, one must review the types of providers involved, the forms of clinical interventions delivered, how effective these services are, and the relationship between costs and outcomes. In conclusion, we at TAP cannot fail also to consider the continuing stigma that is attached to mental health in this country, the need to better understand the dynamics underlying help seeking by parents and caregivers, and the availability of sector choice patterns for children with mental health concerns. Thank you.
Thank you very much for your brief remarks, President of the Trinidad and Tobago Association of Psychologists. And now finally, a representative from the Association of Psychiatrists of Trinidad and Tobago.
I don't think anybody's here representing that association.
Okay. Well, we can then ask members of the committee to introduce themselves briefly before we open the committees to a full hearing. On my right.
Good morning to all. I am Brigadier General Ansel Antoine, retired, Member of Parliament for W. Mira, member.
Yes.
Good morning to all. My name is Christine Uwalo Hussain, Member of Parliament for Kamuto Manzanilla.
Good morning all. Glenda Jennings-Smith, Member.
And I am Senator Dineshwar Mahavir, Chairman of the Committee, Independent Senator. May I, first of all, thank the participants here for their opening remarks. A lot was said, and I really would like to focus on, and it's open now to anyone, maybe the PS of Health or representative of the Association of Psychologists. Under the Children's Act, 2000, Section 30. It says, where a child has been received into the care of the authority, and subsequently that child is determined to be mentally ill under the Mental Health Act, and such determination results in the admission of the child to a psychiatric hospital. That's what the Act says. What I want to get from members of the panel now is whether it is that this child can be admitted to any psychiatric hospital, or are there special facilities available within the healthcare system of Trinidad and Tobago to treat someone under the age of 18 with mental illness in dedicated facilities or facilities dedicated for children? Is there, the question is a simple one, is there any dedicated mental health facility for the under 18 population of Trinidad and Tobago? If there is not, should there be? So let us ask, and the should there be, the is there is for individuals in the Ministry of Health. Should there be is for the professionals in the field. So maybe the Permanent Secretary, Ministry of Health, you can answer the question, is there a dedicated facility for the treatment of children who are experiencing mental health issues, mental health problems?
All right, thank you for the question. I will ask either Dr. Sharp or Dr. Ramtahal to respond to that.
Okay. And Dr. Sharp and Ramtahal, you can also indicate the positions you hold within the Ministry of Health.
Good morning. I am Jacqueline Sharp. I am Specialist Medical Officer, Child and Adolescent Psychiatry in the Ministry of Health. I work with the Northwest Regional Health Authority.
Thank you.
The answer to your first question is no, there are no dedicated inpatient psychiatric facilities for children under the age of 18. And to address your the second part of your question, yes, obviously we need services, inpatient services included for children and adolescents who have serious mental health issues that need to be addressed. There have been various arrangements in the past that have worked, and of course we have children now who are in need of psychiatric care. At this point, if the children are evaluated by a psychiatrist and they need admission, if they're children under the age of 16 and the behaviors are such that they can be accommodated on one of the wards at the pediatric hospital, then we try to make arrangements for their admission to the pediatric hospital. If they're over the age of 16, you try to make arrangements for them to be admitted either to the psychiatric unit at the Mount Hope Hospital that is run by Professor Hutchinson's team, or the children may be negotiated to go to St. Anne's Hospital, usually to the LFE Lewis unit, which is a unit that is for acute care. Those are the arrangements. And in San Fernando, I believe children may be admitted to the San Fernando General Hospital.
Okay. Yes, I see Ms. Nawala Hussain wants to come in, but if she could just hold, may I ask Dr. Chatur to answer my second question from the perspective of the psychologist. Should there be, and the reason I ask this is simple. Children, I imagine, have different needs from individuals who are adults, and they have different coping mechanisms and different problems in coping with the stresses of life. But that is just prejudging. In your view, professional opinion of the psychologist, is there a need to treat children in their own dedicated facilities?
All right, so current data, to answer that question, you have to consider, is the need of children sufficient enough to provide these facilities? Data suggests that up to 20% of children and adolescents suffer from a disabling mental illness. Suicide is the third leading cause of death among adolescents, and up to 50% of all mental disorders have their onset in childhood and adolescence. So with these glaring statistics, sir, you are asking the question, is there a need? And I would just answer, of course there is.
So you're giving a statistic of 20% of children estimated internationally,
yes,
can be experiencing or have experienced some form of mental illness.
Correct.
So that if how the population of Trinidad under 18, do you have any idea what's the population of Trinidad and what 20% of that could be?
I have no idea, but
okay.
Based on my own clinical experience, I would imagine that the numbers are quite great. for children coming in for clinical evaluation. And many of these children, again, these problems go unnoticed, or because they always feel, again, understanding the developmental period of the adolescents, feeling that this is a phase that they are passing through, and it will correct itself when it does not do this.
To get the numbers in perspective, I think around 18,000 children write the C exam every year, so 20% of that would be close to 4,000 children. Would you say around 4,000 children in Trinidad, in say the C cohort year, are experiencing some kind of mental problems on average, which should be addressed?
And to answer that, I would break that down into what are some of the mental issues, because you have from very mild to very severe. All right, and I would say, for a rough estimate, I do not doubt that figure, because especially you mentioned SEA, Mr. Chairman, you have a host of mental issues coming out of just that exam, before the exam and after the exam, when people want to address these issues, the trauma associated with failure. So just that alone, yes.
Thank you very much, and MP Nuwala Hussein will come in and follow up a follow-up question by Brigadier Ansel Antoine.
Thank you, Chair. Just to follow up on the question from Chairman, is there an adequate number of mental health professionals to care with children under 18 years old? And if you can identify how many professionals are there in Trinidad and Tobago? One who can answer, probably you can, Mrs. Chatru. The PS Health?
I don't have numbers.
Who will answer? MP Antoine has a follow-up on that question as well. So
and this is the Ministry of Health. Is there any data of children with mental illness being referred by the courts? And if so, where are they sent if the courts refer them because of mental health?
Again, with respect to the first question, I will ask Dr. Sharp to respond.
Mm-hmm. The question relates to the total number of available personnel in Trinidad and Tobago, or the number of personnel who are employed by the Ministry of Health and the government? Because it's two different questions, really.
We have an act, the Children's Authority Act, which speaks to children receiving the requisite mental health care. I'm asking, is there an adequate number of professional mental health care professionals who can treat with children under 18 years old? And if the answer is no, therefore, are we in breach of the Children's Authority Act because we are unable to provide the proper mental health care for our children?
Yes, the question is, are the requirements of the Act being adhered to with the personnel that you have, or do you need more personnel to comply with the requirements of the Act? Simple.
Their personnel in the Ministry of Health, it's not adequate because we do not have enough child and adolescent psychiatrists. We certainly don't have enough clinical psychologists, and we have absolutely have no speech and language therapists, no occupational therapists, no people doing play and
Let's stop you there. Could you send us in writing, from your technical perspective, what are the requirements, the professional requirements, the professional staff requirements of the Ministry of Health, so that you in your unit will be able to comply with the Act quoted by my colleague? We'd like to get that in writing, because you are saying we have a number of therapists, but I don't know the amount that you would require. And if you could quantify that we need so many therapists of this type, so many psychologists, then I think that would certainly guide the work of the committee when it makes its recommendations.
We will certainly do so.
Yes, please, that I think is critical information, because what your technical officer is saying is that there is an act, the Ministry of Health is charged with complying with the Act, but there are certain limitations, staff limitations that you have, which will not allow you to discharge your functions efficiently. And given the numbers quoted by Dr. Chatur, it means that there is certainly a critical mass which warrants treatment, which is not really receiving it. So, PS, we would like to get what ideally, if from your perspective as an administrator, you would like to see with respect to the professional complement of that unit, which is charged with complying with the Children's Authority Act.
Right. Certainly, Chairman and member, I could also add that with respect to certain fields, it is not just Trinidad and Tobago that has the challenge. The field of child psychiatry, there are global shortages in that field, and therefore, we, as part of the global environment, we are also affected by that. What we have done is place before the National Scholarship Program our areas of priority, including the field of child psychiatry, and it is our hope, if not expectation, that over the next few years there would be people who seek out those scholarship awards, and we can presumably make some difference.
P.S. We are moving in the right directions of finding and crafting solutions now, because if we are short in certain areas, clearly we need to be planning to ensure that we find a professional, we cultivate them, we promote them so that they could provide the complement of staff that you need in the Ministry of Health. But MP Antoine had a question. MP, maybe you'd want to raise your question again for a response, after which MP Jennings-Smith has a follow-up question on the same important matter.
Yes, I'm inquiring any data on children with mental illness being referred by the courts. And if they're referred by the courts, where are they sent, or what is done with these children when they're referred by the courts?
There are children who are referred to the courts who might get sent to St. Anne's Hospital. Usually, these are young men or women who may be over the age of 16, who are remanded for a psychiatric evaluation by the forensic unit. That's one group of children. I do not see those children. They go to St. Anne's Hospital. We also get referrals to the Child Guidance Clinic. I imagine it happens with Dr. Ramcharan in San Fernando and possibly in Tobago as well. Children are referred to the outpatient services, they're evaluated, and reports are written to the court. I can't tell you the numbers off the top of my head. I don't have that information.
But are they sent separately to a children ward, or are they put together with the adults?
The people who are sent to St. Anne's, I think Dr. Ramtal might be able to tell you what happens with them.
Hello. Well, there's no separate children's ward for any such thing. So they are sent together with the adults in the adult forensic unit, whether it is male or female ward. And they are seen there. So there's no separate children's ward for forensics or general psychiatry.
I would like to add that there are proposals that are currently being tabled for consideration to establish at the Wendy Fitzwilliam Pediatric Hospital 4 beds for children and adolescents as a first initiative, possibly with a ward later on. Those discussions are currently in train.
With respect to the timeline, Permanent Secretary, the committee is one that sets timelines because discussions can continue for quite a while without things being done. Is there a timeline at which a determination can be made for that?
The timeline which we put forward in our submission, I believe, is June of 2018.
Okay.
For completion of we're allocating in the first instance 4 beds within the pediatric ward, so it's an integrated service. We want to get away from the whole idea of institutionalization, as PS had indicated. So we're looking at June 2018 in the first instance.
Thank you very much. On June 2018, you may be invited, and we may replay the record. Dr. Chatur has to come in, but then after Dr. Chatur has made her contribution, I want to raise an issue that was initially made by Dr. Sharp, but Dr. Chatur.
I just wanted to say that I'd like Dr. Mawaj to comment on that question, since he's the health administrator at St. Anne's. Thank you.
No, I'm just a correction. I'm not the health administrator. I'm senior clinical psychologist at the St. Anne's Hospital. Prior to 1 year ago, children were seen at the forensic unit of the St. Anne's Hospital. A decision was taken by the psychiatrist in charge, then Dr. Vince, that he would not be accepting any more children referred to his unit by the court. Prior to that year, children coming out of the court system to St. Anne's Hospital were free to mingle with adult psychiatric patients. So at this time, we don't have children coming into the forensic unit at the St. Anne's Hospital.
Dr. Maharaj,
Yes.
I need clarification. The forensic department, the forensic unit at St. Anne's is the one with all the barbed wires and so on that I saw when I visited. Is that that's where you house the criminally insane, I think they call them?
Well,
and you put children in there in the past?
Let's not describe them as criminally insane. The children would be assessed there at times, but they would go to wards elsewhere.
Okay.
Which may seem to be less threatening. So.
Okay, right. Before Children's Authority comes in, Dr. Sharp, I need clarification again on a point. You said that children between the ages of 16 and 18 are sent and are largely treated as adults. But according to the Children's Act, a child means a person under the age of 18. Is it that under certain administrative conditions, you treat 16 to 18 differently from under 16?
Excuse me, sir, I did not say that children between the ages of 16 and 18 were treated as adults. I said that in some circumstances, children who are remanded by the courts for psychiatric evaluation might get sent by the courts to St. Anne's Hospital. And the people who are remanded by the courts for psychiatric evaluation and sent to St. Anne's Hospital are then seen by the forensic psychiatrists.
Okay, it would appear to me then that you will have children 16 to 18, because that's the definition of the Act, who will be basically treated with individuals, adults who are experiencing mental illness. So that is something we need to address. The Children's Authority wanted to come in at this point.
Yes, I just wanted to share with the committee some emerging trends that the authority has seen even as it started operations 2.5 years ago. So we would have conducted some multidisciplinary assessments, which include a full psychological assessment. And we would have developed treatment plans out of those assessments. And out of the 360 treatment plans that we have been able to complete, 137 of the children out of those 360 have presented with some sort of mental illness. Now that's 38% of the children that we have completely assessed. Assessments are still ongoing, some referred by the courts, some through the process of our investigation we determine require assessment. And so what we've seen in the initial trends, I mean, they can't be established as trends as yet, but certainly emerging, it's more than 20%. We've seen 38 of them, particularly the children that we found to be in need of care and protection. Those that are living with mental illness are more vulnerable and many times will come to the attention of the Children's Authority.
Okay. Thank you very much.
Question, but I want to follow up. Could I have you repeat what you just said in terms of the numbers of children that came to your attention?
Right, so what I was saying is out of the 360 full multidisciplinary assessments that the Children's Authority conducted in the last 2.5 years, which includes a full psychological assessment, we have found that 137 out of those 360 children are living with some sort of mental illness.
So could we get a definition of children displaying beyond control behavior and acute mental illness? Can you tell me what's the difference?
Children beyond control is a term given by the court based on my knowledge. It is one where a parent cannot handle, and they would therefore bring the child before a court who will be deemed beyond control. And in instance gone by, they would have been sent to a place or they would have come under supervision. Now, when you talk about acute care in terms of mental illness, you're speaking about a child who might be experiencing some type of mental breakdown or episode, which can in most instances, come across as an emotional or behavioral instability or dysregulation. And as a result of that, that child or those children would require acute care. And that acute care will come in the form of our hospitals or ERs.
So are you saying that children who are classified as beyond control, what happens next to them? Well, they are separated from those that you have just described as those suffering acute mental illnesses symptoms. So could you tell us what are some of the acute mental illness symptoms that you would have experienced?
Before Chair answers, I just want to indicate that we no longer refer to the children as beyond control. The children in need of supervision, because children that present with uncontrollable behavior, they have so many different reasons for it. It's not always that they have a mental illness. And so we associate things that not really associated, which is some of the stigma that we spoke about and the association of the psychologists spoke about. So the two are not synonymous. There are various reasons why a child may present as beyond control. So I would allow Chair now to expound on the...
Before he does that, MP Antoine has a follow-up on the same issue. MP Antoine?
Yes, because, I need to get a definition on interpretation of beyond control behavior as it relates to children. Because you as the Children Authority is saying that you no longer classify that way. But then you also said that it's the courts who says beyond control behavior. But then I also want to find out who determines this categorization. Is it the parents or assessment by some sort of a professional?
Right, so what would have happened before is if it is a parent is having difficulty with their child, before they had opportunity to come to the court and say, I cannot control my child, and the court will deem the child as beyond control. With the passage of recent legislation, the Family and Children Division Act, that has since changed, which was passed in May 2017. They are now referred to as children in need of supervision. So when they come before the courts then have to assess the reason for the children's behavior and then make recommendations to treat with whatever the catalysts for those behavior, instead of just deeming the child beyond control without any type of assessment by all the professionals that the child may need to see. So that is what happens now. That is the transition period that we're in right now.
Thank you very much. I'll follow up now from MP Nuwalo Hussein.
Just to follow up on that comment that you made, you have the courts assessing the child, but does anyone assess the home to determine whether the problem emanates from the home?
Well, generally, from my understanding, in order for a child to be assessed, you have to assess the child's home, the child's environment, where the child frequents, the persons who have care and control for the child. So in assessing a child, you cannot assess a child by themselves. So in assessing a child to come to a particular conclusion, you must evaluate the child's home and all the other factors and elements and domains of the child.
So could you tell us the final evaluation? Okay, so you have determined that child is beyond control. What happens to that child? Where is that child sent to?
Again, if it is a child is found to be unable to be controlled by their parent, we then have to determine why. And that could be anything, and based on that, you make the determination.
Thank you very much. The chair has to come in here, and I'd like to shift. The things are getting very interesting, but really we need to get some solutions crafted. It is determined that there is a problem in Trinidad and Tobago with respect to the mental health and well-being of children. It is determined, certainly from Dr. Sharps and Dr. Chatur, that we may not have the adequate quantity of professionals that will be required to treat with the issues for the 20% of the children who may be so affected. It is determined, and the assurance has been given by the Ministry of Health, by the Permanent Secretary and the Chief Medical Officer, Dr. Parasram, that maybe by June of 18, if the plans are implemented, we can see a dedicated ward at the Mount Hope facility for the treatment of children. Well, it is going to be a start. It is determined that that it is not yet determined that the St. Anne's Hospital is unsuitable for children or may not be the best environment for the rehabilitation. So I need to get the professionals to let me know why the St. Anne's may not be the best. But to redirect the line of questioning now, and I want to bring in the Ministry of Education after the professionals come in. For the professionals, the psychiatrists and the psychologists, I'd like if you could give, certainly me and members of the committee, a breakdown of the types of problems you see in Trinidad and Tobago which are experienced by the children population. And to the Ministry of Education, the law says that everyone under the age of 16 should be in school, and we are dealing with your members, we are dealing with your charges. Within the school system, you have the guidance officers, the school counselors, the social workers. What kind of input do these guidance officers provide in assisting the professionals in Trinidad and Tobago with detecting any mental health issues which children in the school system may be experiencing? But from the professional perspective, the psychiatrists and the psychologists, I need to get an understanding of the types of problems you commonly see when you evaluate children in need of care, mental care. The psychologist first, Dr. Chatur.
All right, so I'm looking at priority disorders here, and I would like just to break the children down into early, middle, and late childhood because the disorders are prevalent in these developmental periods. So in early childhood, we see a lot of disorders as regards learning disorders, so that children who are not doing well in school and who are brought in, let's say, for assessment, dyslexia, etc., they would have associative trauma connected with failing in school. So we have those learning disorders and also hyperkinetic disorders like ADHD, etc. In middle childhood, we see a lot of behavioral problems, conduct disorders and so. And in adolescence, that's why I had to break it down into three, we see a lot of depression with associated suicide, substance abuse here, and a lot of psychoses, which are resulting in a lot of maladaptive behaviors. So dependent on the developmental cycle, I would say that there are different mental disorders associated with that.
As to the various types of problems you deal with regularly?
The psychiatrists currently use the Diagnostic and Statistical Manual 5 of the American Psychiatric Association. So our patients will be diagnosed according to that format. I agree with Doctor in that some disorders are more common at different times of the years, but certainly disruptive and impulse control and conduct disorders are common in mid and later childhood and early adolescence. We have children who have neurodevelopmental disorders, which include things like attention deficit hyperactivity disorder, which is very common, which typically presents in mid-childhood, but can sometimes not be diagnosed until later, depending on whether the child has been labeled beyond control because of the behavior. And when I say labeled beyond control, quite often by their parents or by a teacher, not necessarily by the school system. Children who have mood disorders, and mood disorders can occur in mid and early childhood as well as in adolescence. So at the moment, one of the big problems with adolescents is non-suicidal self-harm, as well as children who are, in fact, making suicidal attempts. We also have children who have anxiety disorders, and anxiety disorders come across the age groups. Children whose disorders are the result of trauma and stress. And at the moment, we have a lot of children in Trinidad and Tobago who are not even recognized as being traumatized because they're the children of murder victims and children who are victims of domestic violence. We know that maybe 68% of children who are living in households where there is significant domestic violence will also be physically abused. or certainly maybe be neglected. And we also have to deal with the issue of, though it's not a formal psychiatric diagnosis, it's certainly in the DSM is recognized as a condition that needs psychiatric attention, and children who are abused and neglected, and they are a large segment of the population, and that includes all kinds of abuse and neglect, including child sexual abuse. All those children need care and attention.
Thank you very much, Dr. Sharp. So that they need care and attention, and they will need it from professionals. So I await the response from the Ministry of Health with respect to the professional needs which the Ministry of Health currently requires to address these issues so that we can make some progress in mitigating this problem. Now, but very important to the Ministry of Education. The Ministry of Education is charged with the education of children, but teachers act in loco parentis when the children are in school. And I'd like to know from the Ministry of Education, as the first responders, the Ministry of Health is the second, of course. Are teachers at all trained? Are they given any kind of training to recognize whether a child may be experiencing some of the problems that are raised by the professionals? Are social workers trained to do that, and do they do it? Are the school guidance counselors trained to recognize a child who is at risk and who may need some kind of professional counseling? Is that done? And if it is not done, should it be done? Ministry of Education?
Chair, I would like to ask Ms. Amanda Pedro to lead off with respect to the response.
Good morning, Chairman and all members. I'm Amanda Pedro, Guidance Officer 2, presently assigned the duties of Manager of the Student Support Services Division. As the PS indicated at the beginning, the Student Support Services Division was instituted or established so as to provide that support for students for holistic development. Listening to Dr. Sharp, we hear the list, the enumeration of all the possible concerns. I would just put a context that at the ministry, there may be as many as over 400,000 students that we have in our care. And at Student Support Services, we have various models to prepare for need. And one of the models we use is that perhaps 15% would have at risk, those that Dr. Sharp has indicated, and 5% with really 5% of targeted need for counseling or therapy. You asked about the training. The Student Support Services provides training sensitization for teachers. The Teacher Development Division also provides more intense training opportunities during the July-August. And the staff at Student Support Services, that is the guidance officers, the school social workers, and what was not mentioned, the term special education teachers, all provide in the districts, the educational districts, and at the school level, opportunities for sensitization for the needs to detect and refer to the internal staff at SSSD. We also have clinical psychologists. We have 5 clinical psychologists and a team of behavioral specialists to assist us internally.
Okay, thank you very much. I need the professionals who deal with children on a daily basis with these mental issues to indicate, we know that the courts refer children to you, but are you satisfied that the referrals for the other group of children who may not be involved in criminal behavior or with any infractions of the law, whether the school system can play a greater role, or is it that you're satisfied with the role of the guidance officers and the school staff in referring the students to you? Professionals, the psychologists, psychiatrists, do you think that they could do more, or are they doing, is it that there's nothing more they can do? Yes, Dr. Chatur?
I was just going to say, in response to your question, I think that the education sector provides a lot of services for children with mental disorders and mental health care needs. And one of the things I had mentioned before is that whilst we see the referrals coming from the pediatric doctors and so to these, for the provision of services, there's no follow-through. You quoted a study in 2000, Dr. Mahabir, about an action plan And that's kind of archaic and outdated, because we have 17 years, and into that mix we have the advent of social media, which has brought its own issues and its own concerns with children, cyberbullying, online bullying, things like that. So it's a kind of cocktail mix. So I think that children implode. They implode a lot, and a lot, as Ms. Pedro said, a lot of these disorders and these mental issues go undetected and unnoticed. When we look at facilities, however, I believe that there are not enough facilities, let's say, for daycare treatment of these children. Whilst there are services, and whilst I think the Ministry of Education provides a lot of services, because we have guidance officers, we have the psychologists, we have the child guidance unit, things like that, we do not have places where children can go just to talk about issues. As a psychologist, I have found what works well with children and adolescents are services like group therapy sessions, because children sometimes don't want to talk with one-on-one only. They want to talk with their peer group, and I think this works well. I just want to mention here that, for example, the Ministry of Education has something like learning centers or homework centers. And these, I think, could be an excellent base if they are brought back for group therapy sessions for children. But we do not have facilities and enough personnel to deal with this.
Okay, so to answer the question I posed, is it that the support staff at the ministry, at the school system, the guidance officers, the social workers, do you think that they are doing an adequate job in identifying the at-risk students so that there can be a treatment at an early level? Because at one point in the discussion it was indicated that many children go undiagnosed. And now, if it is that they go undiagnosed, clearly they are slipping through. There are professionals who are not seeing them. The question is can the school system do more, since all children are mandated to be in school? And if they can do more, what could be done to ensure that they actually do more in sending the at-risk students for the treatment that they need at an early stage?
And I do not think this has to do with the quality of service provided by school personnel, because many of them are professionals. I think it has to do with the understaffing and the lack of sufficient personnel, because you said they slip through the cracks, and children do. Because you have, and I think the Ministry of Education is better poised to give you data here. You have one psychologist or one guidance officer dealing with 2 and 3 schools. And again, it's the understaffing or the lack of personnel within schools to deal with these.
Ministry of Education, is it possible for you to send to the committee information on the number of students over the last 5 years, I don't know if you collect that data, who were identified by your guidance officers and social workers and referred to the various agencies for assistance with mental illness?
Yes, sure, we will do that. But if with your permission, you spoke about whether the service being provided by the ministry is adequate in terms of identification of students in the context of those who may be falling through. We have recognized that one of the challenges we have is in terms of that initial screening, which can highlight challenges students have and those who need support. And we are actually currently working systematically towards, and it is our intention within the next 2 or 3 years, to have all students in primary school undergo that first basic screening. We also recognize that there are some issues related to staffing and the number of persons who can adequately address some of those needs. And we are actually addressing that, of course, financial constraints given, but we are trying to complement the screening and the service that we provide by looking at staffing issues within the ministry, so that we are aware that there are some gaps and there are a number of students, as you indicated, who we miss. One of the areas where we can certainly benefit from additional support is in terms of those students who we identify for follow-up services. That is an area where we have some challenge in terms of once we identify, and usually it's the ones with the more severe symptoms, that service, I think, is important for us.
Very much. Thank you very much, Ministry of Education. According to Ms. Pedro, your guidance officer too, I think she indicated that some 5% of the school-age population may be experiencing some acute mental disorder. Now, if the figure you told me is 400,000 students within the school system, 5% would be about 20,000.
Can I just correct that?
Yes.
The primary and secondary school, based on our data that we currently have, it's more in the vicinity of 225,000. Right. And at the ECC centers, we have about 36 to 38,000 students.
So maximum 250,000.
Yeah. So
if we are taking 5% of that, that would be about what, 5,000 children?
It could be in that vicinity. However, as I said, we recognize currently that the numbers we are getting based on either diagnosed or suspected may not be picking up all the students, so that as we move ahead in terms of strengthening our initial screening process and putting systems in place, we expect to get a true reflection of what exists.
Okay. Let's just assume numbers, 10,000 students, according to the 5%, whatever the population is. I simply would like to know, of the 10,000 students within the Ministry of Education, how many of these, and these are students not with the mild disorders that Dr. Chatur spoke about, but they have serious problems. I would just like to know whether your officers are trained, or should they now be subject to some kind of training, preliminary training, so that they can identify the bulk of these 10,000 students. These, of course, because what Dr. Chituru said is that some of these students suffer from disorders that can lead to some really serious outcomes. So that I'd like to know how many of these students were referred, and whether, in fact, there is a gap there between what your officers are doing and what, in fact, they can do to identify the 5% seriously at-risk students within the school system.
Chair, I think, well, you spoke about training first, and that is an ongoing process within the Ministry of Education. We have leverage on various training opportunities to upskill our staff, and that is, as I said, that is ongoing. One of the things and the area that we are addressing currently is, I guess, financial constraints force you to optimize and maximize efficiency. And so we are currently looking at how we can reorganize the services that we provide so that we can become more efficient. In terms of giving you a figure, I'm not in a position at this time to
Quickly understood. You see, we are trying to identify the source of a problem which has existed in Trinidad and Tobago for quite a while. And what was indicated to me at another committee is that the people who are suffering, not only children with mental illnesses, are usually identified by lay people who think that maybe a person should be, it does not have to be a psychiatrist or a psychologist who will suggest that this is an individual who needs treatment. The people they live with, and in the case, and that's why I mentioned teachers and the officers in the school act as parents in situations where parents may not be identifying the problems. I simply was inquiring as to whether the Ministry of Education sees a role in this area so that it can pick up the 5% indicated by Ms. Pedro.
Absolutely, Chair. I just wanted to comment because in an earlier contribution, we tried to establish numbers of specialists, those persons who will provide the service. In the Ministry of Education, mental health is one area along the spectrum that we treat with, and there was a whole list of areas that we saw. So that a layered approach, so when we spoke to basic screening, is really starting from the level of the teachers at the school and parents in terms of providing them with ongoing training and support in terms of that early identification. We have established school-based teams who will then look at these cases that teachers may identify or suggest there's a problem. And then we have another layer where, depending on that discussion, we have our special education persons or student support services personnel who can now intervene and determine whether some of the things, as I said, lie along a continuum, and therefore suggested strategies and intervention can take place from the level of the teacher in the classroom. Really, it's those cases which require professional treatment are brought forward, and therefore, in the consideration of the number of persons and the personnel required, I think we have to look at it in terms of the strategy. At what level do we need the specialists, and we refer students outside the system as opposed to those who we need within the system.
Yes. Thank you very much, Chief Education Officer. And we have two follow-ups.
I really want to ask some serious question here, because you see, this morning we have been talking a lot about 5% and world standards and stuff like that. I want to be real here. I asked a question to Ms. Noel about the number of cases that were brought to you, and you told me 360 persons over 2.5 years. I want to ask the Permanent Secretary and the Chief Executive Education Officer, tell me, what system you have in your schools? Because, and I asked a question before, and I want you to remember these questions I asked. I asked, what is the definition of beyond control? And then I heard you speak, and you quite correctly spoke about the continuum of behavior with children, right? And I want you to tell me in numbers, 100, 200, 300, don't give me no percentage. Give me in hundreds. How many children in your school system have been identified as mentally ill children, or sent to the Children's Authority, or sent to the courts, and have been determined mentally ill children? I need to get that figure in numbers.
Question is a simple one from the member. She wants to know the amount in terms of a number that was evaluated.
And I can make it easier. Separate children who have been determined beyond control and children who are deemed mentally ill.
Okay, I am Leticia Rodriguez-Cupid, a member of special education teacher, currently assigned duties of coordinating special education services. From the current, just to be very direct, the current referral data, this is students who are currently referred to student support services. The cases falling under mental health issues would be about 243. The numbers I have exactly is 243 students who we are currently treating with in terms of mental health. A large percentage of those have been diagnosed with ADHD. 54 of them at this time have been diagnosed with various emotional behavioral disorders. We do have a number of other students who may have what we call comorbid disorders, which will include ADHD, emotional behavioral learning disabilities, that number is not disaggregated, but that number is a lot larger, 476.
Mr. Chairman, so therefore, I want to be practical and real, because we are in Trinidad and Tobago today, and we are in a particular situation, financial-wise, and I heard the Chief Executive Officer make mention of that. Chief Education Officer, sorry. And I also heard reference being made to we have to maybe wait until 2018 when we could advertise positions for other, to fill positions to deal with the situation at hand. And I want to know, bearing in mind what we have right now, because are we certain 2018 could facilitate the paying of salaries for these additional staff? Bearing in mind who we have and what we have right now, what plan is being made to deal with the situation at hand now? Because this is not a situation which is beyond doing. It is a very doable situation. But how are we looking at the situation at hand and making an effort or an attempt, or don't tell me a study because that will be next 2 years, or an attempt to deal with this situation, with these numbers at hand? Because Safia said she had 360 and she ended up with 137 needing attention. The school system gave me even a more realistic figure. So now I'm talking to the heads. I'm talking to the president of the TTAF. I'm talking to the chief medical officer. And I'm talking now also to the Chief Education Officer. Tell me, what can we do now to deal with the situation at hand, given our present economic challenge in this country?
I would like to address that, Senator Jennings-Smith, and I want to be real here. You have asked a lot of questions that I do not think there is sufficient data. Only because for a lot of these action plans to be implemented, there has to be policy, there has to be law, and that's where you people come in. Dr. Mahabir has talked about an action plan 2000. 17 years have gone by, and according to Dr. Maraj, nothing, hardly anything has been implemented. We are here to review mental health care amongst children and adolescents, hopefully to devise action plans, and hopefully so that some kind of policy and laws are implemented. The bottom line, and I'm being real here, we don't have people to document. Documentation is important. Secondly, we don't have personnel in the schools and in, I imagine, other professional services to provide the kinds of services needed for children. That is the real situation. Right. I don't know if anyone else can.
But here is something that has just come to hand. We are seeing a major slippage between the data presented by MP Jennings-Smith and the fact that Ms. Pedro has indicated, MP Jennings-Smith, and that 5% of the student population may be in need of some major intervention, the 5% amounting to 10,000 or 20,000. I'm wondering from you, Dr. Chatur, whether, in your opinion, a module can be prepared by you and people in your profession to train the social workers and the school guidance counselors in early detection. I know that this is a troublesome issue, but in the medical field, there are paramedics who are there to deal with a patient on accident, and the doctor looks after him afterwards. Is there a module of training that you can offer to the school guidance officers and to the teachers of Trinidad and Tobago so that they can identify at an early stage the children who may be most at risk so that there is early diagnosis and early treatment, and in that way, the problems do not exacerbate and continue into adult? Or is it that you cannot do that? Such a training module cannot be created?
In 2011, Dr. Mahabir, the Association of Psychologists, proposed a plan to deal with all that you have said. The reality was that no monies were allocated and no approval given for trauma centers or anything where children were concerned. 2011, 6 years have gone by, and you're asking us now, can we come up with a plan that we have done before, a plan that we have proposed to government before?
I'm not asking you to come up, I'm asking you as a professional.
Yes, we can.
So you can take...
Give us the money and we can.
You can take the psychologist, the school guidance counselors, and have them in a session for 2 hours, and you can train them to identify. I'm looking at practical things. In 2 hours, you can give a module. You see, as an old educator myself, I know what is possible and what is not possible. But can you offer that rudimentary training so that having undertaken that course with you, they would be better prepared to identify? There may be one guidance officer in a school, in their school population, they may be in a better position simply to identify. Because you see, MP Jennings-Smith raised a very valuable point. Only 300 students or so seem to have been diagnosed. And clearly, there is a problem. And I'm seeing Dr. Sharp coming on, but I will ask the Dr. Chatur to come in first, and then the psychiatrist, Dr. Sharp, to come in afterwards.
I'm here, my colleagues around the table. These people are professionals, Dr. Mahabir. They have been trained in techniques. I think they, whilst we can do a good job, I think they can also train their staff.
Okay.
And they do.
But if it is that's the case, why is it only MP Jennings' numbers are coming up 300 and something patients? You see, the question that is coming to me is this. According to Ms. Pedro, 5% of the students may be at serious risk? Are we picking them up? If we are not, why?
But Mr. Chairman, based on what is she saying that? What is the evidence to say that?
Excuse me? Yes. The model that I'm explaining suggests that the students would, 5% may have serious needs that require intervention. They may not be all mental health care. Some are environmental situations, but they require intervention. So I'm saying that when the student support services was set up, it was set up for us to have that awareness of, sensitization to teachers and parents to be able to meet those needs. So there will be a discrepancy, but it is, to my mind, it is a very important figure to be aware that there are children under environmental factors, social challenges that require intervention.
May I ask a question?
The social worker, the senior social worker, to intervene as well?
Before you intervene, I just want to ask a question. The low figures that we're seeing here, is it that parents must give consent?
Privacy, correct.
So therefore, is that is reflective of the low figures because parents have not been consenting?
No, we cannot say for sure, but certainly that is a factor.
Okay,
because
and
the
next thing is that understand that teachers are being trained and so forth, but understand they are there obviously, but what initiatives have been taken by the Ministry of Health and other stakeholders to improve public awareness of mental health illnesses affecting children and adolescents so that even the public could be aware and they could bring it to the forefront? You know, what is being done to bring public awareness?
If you would allow the social worker to address it, because we have been taking a social marketing approach, and she would have some valuable insight there.
Yes.
Good morning, Chair and committee members. Sharon Francis Gaines, social work specialist. During the period of 2012 to presently, the social workers have been receiving referrals from students. We have received approximately 563 referrals from students with self-harming behaviors. And the self-harming, and I have the data available. It's broken down between self-mutilation, suicide ideation, and suicide by threat. And it's broken down into the districts. When we saw the data, we recognized that a greater percentage of the data represented suicide ideation. As a result of that, we took an initiative where we decided to develop a strategy, an intervention, because we recognize that it's a community approach as much as it's a mental health issue. In providing a community approach, we reached out to Ministry of Health, a number of our stakeholders, members from the OPM, Office of the Prime Minister, Gender and Child Affairs. We met with a couple of the stakeholders and we discussed the gaps that has been identified as to questions as to why our students are not reaching out. Why are they not talking? Why are they remaining among themselves? They're searching the internet and they're getting information on behaviors, self-harming behaviors. What can we do to intervene? As social workers, we have gone into the community. We have met with the parents. We have done home and family intervention and assessment. And we also felt that the parents were also keeping a lot of issues to themselves because they were unable to share. In some cases, they were challenged with in terms of getting assistance. In some cases, they really did not know how to. As a result of that, when we recognized that a percentage of the students were actually using the social marketing, we decided to run a social marketing campaign at the Ministry of Education as one of the outlined strategies. With the social marketing campaign, it began in on November 25th, 2016, and out of the data, we identified approximately 25 schools. I need to check the data exactly, the number of schools. And from the schools, we identified students who were willing to share preventative measures with their colleagues through social marketing and artwork.
A follow-up on that, because something is very unclear to me. And what is unclear to me is this. You see, Ms. Pedro indicated that, and it's an international norm, I'd imagine, 5% of the population, the student population, experiences some major mental illness or some major
not mental illness, but challenge.
Some major challenge, yes. And I just would like to know, of the 5% experiencing this challenge, how much of the 5% is identified by the social workers and the school guidance officers in the school system? Is it 1%, 2%, or do you identify the full 5%?
It's an integrated approach in the sense that if the initial screening begins at the level of the school with the guidance officers, because there are guidance officers present at most of the school in terms of the ratio. When the screening begins, and the referral comes to the MDT, the multidisciplinary team, in most cases, and it's different for primary, and it's also different to the secondary in terms of the treatment. We meet, and at the meeting, through the conferencing, the assessment is done, and we decide, the decision is made as to the persons responsible for certain aspects of the intervention. If it's home and family.
That's your process, that's your procedure. I'd like to know of the 5%, really. And the 5%, let us say, would be 100 students in a school. It's a large school. Of the 100 students who are experiencing that major problem, mental or problem, how many of them are picked up and how many of them are undiagnosed? Because that to me seems to be the problem. If you are able to identify every one of the 5%, then you have been able to identify, and then it goes through the process. But if you are only picking up 1%, that it means 4% of your acute patients are undiagnosed. And I really would like to know, what is the rate realistically you think that you are able to identify from the practice that you have? Because that is going to then flow, you see, to the Ministry of Health, from the Ministry of Education to the Ministry of Health, to the Psychology Department, to the various services. So I need to get that figure. Are you identifying your full I'm not talking about the other 15% who have mild problems. The critical 5%, how much? 1%, 2%, or is it that you are satisfied that you are identifying the full 5% of those students with major challenges? Straightforward question, I need a straightforward answer.
Yes, Chair. I understand that you need definitive, you need data, and you need it for us to be clear. But looking at the information that's provided, it has been disaggregated, but when I look at it, there are gaps.
Yeah.
Yes? We have quite a lot of gaps in certain areas because of it. If it's for example, it's in the Port of Spain area, because it's a referral and it's a case basis, you find that the data may be more reflective of what is happening in our school system. As we go down, for example, if I pull a district, Northeastern, I'm not seeing the type of information that will, right? Because again, once it's provided across a category, there are too many gaps. So at this point, what it needs is that we need to be able to definitively say, as CEO would have indicated, the screening must be done, because most of our student support is by referral. It is not where we screen and we detect, or we have teachers who are referring the information. Right. It is those cases that come up to us and we see a need to respond, we respond. So it means that our system needs to be relooked at, and our data collection has to be.
Thank you very much, Madam PS. Yes. That is certainly, I think, the practical way to go. The first responders in my mind ought to be the employees of the Ministry of Education. And I'm simply, the question that I had posed to Dr. Chatur, I did not get a clear response. And I like clear responses to my very clear questions. And that is, do you think now as PS that your teachers, the teachers who are employed by the ministry and who deal with the children on a daily basis, the social workers and the guidance officers will benefit from some kind of exposure where they will be able, as part of their job description, and they are trained now to discharge that function, to identify, so that we can screen as early as possible the majority of the critical 5%, and hopefully with the progress of time, we will be able to catch maybe more and more of the 20%. Do you think your officers will benefit from that? If not, well, they won't. Then we'll find another mechanism. If they can, then maybe that's a solution that we could start to implement without looking at any grandiose plans, certainly things we can do at the school level on the ground, so that we have a throughput that we send to the Ministry of Health, and because the Ministry of Health would be preparing itself to deal in time with the throughput. But you can't have all the professionals in the Ministry of Health and the people who are in need are not being identified at an early stage. So I'd like to know, what your plans are. Maybe you can put it in writing. You can discuss with your technical officers, discuss with your social workers, your school guidance officers, as first responders, the teachers, on whether, in fact, this is a program, because what Ms. Pedro has indicated to me is a worrying statistic. 20% in general suffering from some kind of disorder or some kind of problem, but 5% being acute. And we want, at least at the beginning, to pick up the 5%. And I think we can't rely on others outside the school system only. I think the school system should play a role, because in law, as you know, the Education Act says, the teacher and the principal will act as loco parentis in the absence of the parents when the children are under their charge. So I think it's something that I direct to the Ministry of Education, how you are going to address this issue of identifying more and more the 5% that is at risk.
Mr. Chair, I just want to say, as you're on the 5%, I think, you see, it's a danger when we play with statistics and percentage and numbers. And before we present and we generalize based on a basic assumption, right, and a part study, we run into, wrong calculations and wrong assumptions. So that's why I'm concerned this morning when I saw this basic submission by the Ministry of Health. And I want to really question, what was the population used to come up with this particular
MP Jennings-Smith, I have to intervene here. Yeah, we will look at the statistics and look and see whether they conform with international norm. But MP Nawala Hussein has to leave, and once she leaves, we will not be quorate, but we will continue the taking evidence. Of course, with the leave of committee members, we will continue the taking of the evidence. So MP Nawala Hussein, you can pose your final question before you leave, and then we will continue taking the evidence.
Thank you, Chair. My apologies that I do have to leave early. But just to ask a question, and that is Dr. Mahabir had indicated earlier in his statement that the children are taken to, who are being evaluated, are taken to the forensic department in St. Anne's. And I'm wondering, is there a psychiatrist or psychologist on site at all times, 24 hours a day? And if not, how long would the child will be required to wait to be evaluated? So that determines really how long the child remains in an environment that is not healthy. And if there is a case of concern, would the ministry consider looking at the Cuba's Children's Hospital as a facility for the treatment of children with mental illness?
Yes, Dr. Maraj, you can come in, yes.
Yes, Miss Member Hussein, I think she called me Dr. Mahabir, and it's Dr. Maraj, rather. Sure. The employ of forensic personnel, like forensic psychologists, is not at all 24 hours. It's usually 8 to 4. And we try to get an assessment done 2 weeks or less once the child is admitted. So that's how we have been operating in the past.
For the child is in an environment that is basically unhealthy because the child is among adults.
I think you've said it correctly, yes.
Very well. I see Dr. Ramtahal wants to make a contribution.
Yes. When the child is admitted, we have doctors on call 24 hours at St. Anne's. So the child will be seen on admission by a house officer, a junior doctor, and then by the next day or morning, he will be seen by a specialist. But as Dr. Maraj said, we have been reluctant to accept the children since Dr. Vince had decided, well, he has resigned now, but he had decided that we had no child psychiatrist there now. As such, we were not in a good position to write reports on children to the courts. So at this stage, we haven't been doing the children sent by the courts. We have asked them to not send them there. But to answer your question, yes, they have been mixing with the adults in previous years. Yes. And that is not ideal.
Okay, very well. Thank you, MP Hussain. You are excused. Right. MP, do you have a further question?
I really just made a statement because I find that, you know, we are going along a line of the 5% and generalizing a study into another population, and I feel it could be dangerous. So I think I just wanted to make a statement.
Right, very well. Okay. Yes.
You asked earlier about training and whether the ministry and the school personnel will benefit. Simple answer to that is yes, and that's an ongoing thing that we have, but any support there will be welcome. The other question you asked is about trying to close that gap between those we diagnose and those we miss. And the ministry is in fact working on a strategy right now where the intention is after 3 years, we will be down to screening every child at the level of standard 1 in a primary school. So we are doing it on a phase basis, starting with 2 levels at a time. But the design is that after we go through that and make our assessments, that going forward, every child at the level of standard 1 will be screened, and that will certainly impact on our ability to, first of all, assess the students who are coming through and any support that is needed, but going through the system. So there is a plan within the ministry.
Yeah, just to follow up with respect to the screening has to be done by individuals, of course, trained in screening. And are you satisfied now that if you get your full complement of school guidance officers and social workers, that with the current skill set that they have, they will be able to identify the at-risk students? Or do you think you need to consider how they are going to be further trained to evaluate these particular at-risk cases?
Ongoing training is certainly one of the things we're looking at. But you mentioned, and I think we agree with you, that there is also a big role to play for teachers and school personnel to play in that initial screening. The current staffing we have, and if we get all the positions filled, will certainly augment so that if there are symptoms or signs detected in the classroom, and those could manifest in many ways, it could be student performance, it could be behavioral. Once that happens, then there's a next level so that the student support services personnel do not necessarily have to, but we can train school personnel to do that early detection. So we are looking at it in a systemic way so that some of those early detection, as I say, because it's a longer continuum, we can put strategies in place from that level. Those who need further support from persons within the student support services or the clinical and behavioral, and if it requires referral outside of the ministry, then we take it. So it's a multi-step, multi-layered approach that we are using. Certainly we are looking at training. Currently, we have done some training, so there are persons within the system who can do that at the school level. But we intend to have that training on a consistent and ongoing basis so that we have enough persons at the school who can be involved in that process.
Okay, and to the PS education and the chief education officer, I know there is always a close association between the Ministry of Education, the school principals, and the community police, where children who are displaying antisocial behavior or unacceptable behavior are referred to the community police for some kind of guidance before they take them to the court system. The Children's Authority may be involved here, but I'm simply wondering, is there scope for closer collaboration between the Ministry of Education and the Ministry of Health, where one of the first professionals you call in is a psychologist at the Ministry of Health to have some kind of interaction with the child? Does it currently exist or does it not exist?
Let me deal with the community police. The community police and that partnership, whether through the programs that they run, is one that we have been working with for some time and we are continuing to strengthen. I don't want it to be misconstrued that we are using the community police to address we have persons within the student support services who will do that initial assessment and support. We work in partnership because there's a role for the community police. We are, in fact, working towards strengthening the relationship between Ministry of Health and the Ministry of Education, not just in terms of mental health, but, for example, healthy lifestyle, physical fitness. So that is ongoing, and we will continue to engage and collaborate if there is need. So, for example, some students where we diagnose who may require psycho-eds, we may refer to child guidance clinic or psychiatric support, or in some cases we are trying to also utilize, we have some provision within our budgetary allocation to outsource some of these. So we do that when it is needed.
Right. So I'm trying to get the process clear. There is a child who has been identified as at risk and in need of treatment. The school guidance officer or the social worker will inform the school principal, and does the school principal then inform the professionals at, say, Mount Hope psychology unit that we would like for you to evaluate this child, we think this child is at risk, or does it go through a different, you see, I'm looking at the collaboration, if any, which exists between the Ministry of Education and the Ministry of Health. Children suffer from these mental traumas all the time, and going through the court system is one route, but going through the support system you have and a closer collaboration with the Ministry of Health, do you think you would be able to minimize time and maybe secure treatment in a quicker way if the school guidance officers and the social workers are empowered to inform the principal that I think you should talk to the professionals, psychologists as soon as possible on this one?
Okay, just to clarify, in terms of referral to the court system.
Dr. Sharp, you'll come in after.
There are incidents which require us to report make reports to, and those will go. However, in terms of the engagement with the student support services personnel, it's a collaboration with, so an incident may happen at a school or there may be certain observations. The principal or staff member from the school will make a referral to the student support service, the guidance officer or the special ed person. They will then do their assessment. If required, they may intervene, or if required, they are the ones who really take it to the next level. So there's a clearly defined referral process within
Very
the
well.
ministry.
Dr. Sharp wanted to make a contribution at this point.
Yeah, I would like just to refer to the issue of referrals. Child guidance clinics, there's one in San Fernando, there's one in Tobago, and there's one in Port of Spain. The one in Port of Spain serves the Northwest, the North Central, and the Eastern Regional Health Authority. Children who have psychological problems identified in schools are referred to those clinics. At those clinics, the children have full psychiatric evaluations and treatment if indicated. In 2017, the Child Guidance Clinic had 386 referrals from all over. Of those 386 people who were interviewed for a preliminary interview, 284 of them returned for their psychiatric evaluation. Child and adolescent psychiatry, like psychiatry in general, is governed by medical ethics, and therefore we have to have consent to do treatment. So parents can refuse consent. Children, for the Child Guidance Clinic, we had referrals from the Ministry of Education, the Student Support Services Division, and the Child Guidance Clinic work closely together, and we have a system where children in primary schools who are referred to Student Support Services, we then collaborate. It is not every child who is identified with a psychological difficulty that needs to have a full psychiatric evaluation.
Okay, one follow-up. Are you satisfied that the 386 student children who were evaluated represents the best percentage you can find of the acute cases? Are you satisfied with that number, or do you think, given your experience, professional experience, the number can be more?
The 386 include children who are not at school, and I want to really raise the issue that there are several children in Trinidad and Tobago who are not in school. They're not in school because they're underage, or they're not in school because they have disabilities, or they're not in school because they're not in public schools, because they're in private schools, because they have developmental difficulties that the general education system does not provide for.
That is understood.
Excuse me, sir, they are a part of a population that has significant mental health needs. That includes several children who are on the autism spectrum, and they are institutions, not government institutions, that are working with that population of children, but many of those children's parents cannot afford the services. There are private psychiatric services in Trinidad and Tobago that provide some service for some of the population.
Okay, as a professional, now, yes, it's my turn to speak. As a professional, I'm asking you, of the number, very simple question, 386 identified. I know they may have been identified elsewhere. Do you think that we are identifying the majority of students who need the care and the treatment, or do you think we need to make much progress in identifying and detecting the children who are in need of this care? The question is, your experience is wide and it's vast. You have picked up 386 within a particular population. Is that, you think, the optimal number, or do you think we are missing a good bit? The answer is either you agree we're missing or we are doing very well.
Yes, I think we're missing a segment of the population, but just to say that, we need then to figure out why we're missing that.
Excellent. We'll have to identify why we're missing.
Part of the population that needs to be screened are the children who attend the public health facilities. Yes. So there is developmental screening happening at the health offices. Part of the difficulty there is that there is a lack of professionals at the level of doing the diagnostic work.
Right.
And if you screen and you do not have facilities to do anything more than screen, two things happen. People think, well, why are you wasting my time?
Well, currently, you see, when I see a figure of 386, I think it is a really low figure. And it does not justify the additional staff that you are speaking about. So clearly, could we get something in writing as to what the population of at-risk students who remain undiagnosed might be that will justify the increase in the staff that is warranted by the Ministry of Health? Dr. Chatur, you wanted to come in?
Yes, I wanted to say, as I said in my opening remarks, one of the key players in the provision of mental health services in this country, I think, is the education sector. Teachers have become the line of defense by default. They are the ones who recognize, they are the ones who can recommend. So to that end, because still in Trinidad and Tobago, there's a stigma attached to mental health. How many parents who know that their children have mental issues would seek help? Yeah. All right? Because, of course, it would be stigmatized. So I do believe that because of that, teachers have become the first line of defense. And they should be trained, as you suggested, to identify, because you said 5%, let's look at that figure. I think it's less than 1% that we are recognizing. All right.
Your experience is that we are identifying less than 1% and that there is scope for further identification. Yes. Your recommendation is that teachers can be trained to identify up to the 5%.
At least to recognize and refer, because they are not trained to deal with the issue,
to recognize
and refer.
Right, and you think that there can be, therefore, closer collaboration between the Ministry of Health
There has to be.
And, say, your profession in identifying the at-risk students.
Yes, and in my opinion, I said there needs to be service integration between the education sector and the mental health services. That is a need.
Okay.
Yes.
And right now you're saying that that collaboration does not exist.
No.
What will you recommend, therefore, as to the committee as a possible solution? Because you see, my concern is the identification of all the students who are in need of care must be identified. Well, not all, but the majority of them. And you say that it's not necessarily happening. what is your recommendation to the Ministry of, to us and to the Ministry of Education?
Sorry. The first thing we know is always public health education.
Yes.
All right? To decriminalize the stigma attached, and that is necessary. I know the public health sector has, I think, stated this morning that some campaigns are being done. But I think that, if we're looking at the first step, that's a first step. We need also to really devise a child and adolescent mental health action plan. We need that, not a general action plan, but specifically geared towards children, to establish our approach to care, to utilize all our means of treatment, and to put that as a priority.
Okay.
Yes.
Very well. Yes. Okay, there's a follow-up, and then Dr. Rabdahal will come in.
I have a question I want to put to the Chief Education Officer. Are you satisfied that your institution is failing in its activity to identify children beyond control, mentally challenged children? Or are you satisfied that you have a promising program that seeks to deal with the reality of the conditions and the economic challenges of our country? Tell me, are you satisfied? And are you satisfied that you are getting sufficient assistance from professional bodies, external professional bodies, in your plan to deal with the situation at hand, given our economic circumstances?
You've thrown a few curveballs at me. We recognize in the ministry, and I recognize, I guess it's something that we agree with within the ministry, that there are gaps in terms of students we are picking up. Based on that, we have identified a strategy, that early basic screening, which we believe, and if it can be rolled out the way we have it planned, at least every child coming into the primary school system at standard 1 will be exposed to that initial screening, and therefore we strongly believe that can contribute to closing that gap we've identified. The approach that is used by the Ministry of Education is not one which deals with mental health alone, but with a whole spectrum. And therefore, our approach to that early screening will throw up students who have symptoms associated with mental health to other learning disabilities or challenges. I think we have a strategy that can certainly significantly improve our ability to provide the service that we are being asked to provide. I also am convinced in terms of the support that we need, because there's also, I think several speakers spoke to the follow-up, and there's certainly the need for us to get that additional follow-up in terms of students where we may not be able to treat with directly, but who may benefit from another layer of intervention. Some of the specialists and experts maybe outside of the ministry. One can always argue that additional resources and maybe if we increase numbers will certainly contribute, but as a ministry we have to plan within the budgetary constraints we have. And I think certainly what we have on the ground now with the current reality will significantly improve what we are doing.
Okay, thank you very much, Chief Education Officer. You indicated to us that screening is going to start relatively soon from Standard 1 all the way up to the C exam level. We don't know when that is going to be rolled out or implemented. The question that was posed, and I want to reiterate from MP Jennings-Smith, is are you now satisfied that your staff is doing all it can to identify the students at risk, or do you think that the staff in the Ministry of Education will now need to place some kind of priority on the mental illness of children so that the numbers identified can be more realistic and reflective of the population of students at risk, I'd imagine, in Trinidad and Tobago?
Okay, there are two things here. One, in terms of what we currently do and how we do it, certainly we can improve in terms of the detection and all of that. I think that with what we are planning to do, not separating, and that is something that we need to look at in terms of strategy. It may not be practical for the Ministry of Education to focus on the needs of students by truncating mental health and the areas under that, special needs, learning disabilities. In other words, we have to start broad and identify the spectrum, the next level and the next level of intervention as required can then put students into, so for example, ADHD, our strategy will identify students with ADHD or some other area. So I don't think we need to change strategy in terms of how we are proposing to go forward, but certainly that strategy will contribute to the a higher level of identification of students who may need mental health support.
Yes, thank you very much. Oh yeah, Dr. Ramtahal has one comment to make.
I think some of these questions are difficult to respond to because I don't know if any countrywide epidemiological data on prevalence rates or incidence rates of mental illnesses in children and adolescents in Trinidad and Tobago. So what is the benchmark? What are we measuring? How could we ask if somebody is succeeding at something if we don't know what are the basic baseline prevalence rates of these conditions in the first instance? So some of the questions are difficult to answer, really.
Yes.
We should in addition, we should be cautious about the figures we are hearing in the absence of those studies.
Right, so we should start collecting the data. We should start collecting the information because there are resource implications. The resource implications for the Ministry of Health, as indicated, is that there is the need for a number of professionals, and we need to know that there is going to be the demand for them, so that it comes back to the initial position. It has to be that ground level staff are collecting the necessary information, doing the basic rudimentary evaluations, so that we could at least send for further evaluations to the professionals charged with that responsibility, is the people who are most in need. Because what is of concern to me clearly is that there is a question on the figures provided by, say, by Ms. Pedro, but without any contraposition that the figures may, of course, be less than that or more than that. So we do need to collect the data. We need to start at the school level, since children are supposed to be in school, in my mind. And once we are able to get the professionals in the Ministry of Education to do the basic screening, as Chief Education Officer indicated, then of course we will understand and appreciate at the parliamentary level the needs of the Ministry of Health and the needs of the Permanent Secretary and his Chief Medical Officer on how they have to gear up for this particular problem. So may I just recommend, before I ask for closing comments, that the Ministry of Education seems to be the first line here. Children have to be in your institutions by law. They under 16, we ought to be in some form of education. Certainly under 12, we ought to be in primary school. That's what the law mandates. And therefore, we should be able to identify that captured group. Our professionals in the school system ought to be keenly aware of what to look for. I am not sure that they are. Dr. Chatur has indicated that they can be subject to some kind of treatment to make them a little bit more aware, so that they are able to identify more and more students who may be in need of care. And once we are able to do that, we will be able to address the concern of Dr. Ramtahal and MP Jennings-Smith that we need to get the data, the statistics right. We do have international standards, international norm. We hear 1 in 5 persons suffering from mental illness, maybe 1 in 5 children also experiencing that problem. This is just casual observation. So I think we do need to start collecting the data. And more important than the data, behind each datum point is a person, a child in need. And we need to identify those children in need, because as rudimentary as there are, facilities exist in Trinidad and Tobago. once we are able to identify the children in need, and I think I look forward to the Ministry of Education starting their screening, so we will be able then to really capture the group that is in need and ensure that the problems they are experiencing are not exacerbated. So at this point in time, I will ask in this particular order, closing remarks from the panel, and then I myself will close with a few words. So may I ask the Permanent Secretary, Ministry of Health, to offer some brief closing remarks on the subject under inquiry.
Thank you, Chair and members. The Ministry of Health commits to continuing to work with the Ministry of Education, as you already do with respect to the training and in respect of the referrals that we receive from the Ministry of Education and the services that we provide there. We will continue to work with them to more fully integrate with that ministry as well as other agencies to ensure that the quality of our services improve.
Yes. Ministry of Education?
Yes. The Ministry of Education recognizes as first responders that we are responsible for the data in terms of understanding, as what was said earlier, in terms of the baseline prevalency rate, that we also need to disaggregate the data in terms of what was said in terms of primary ECC, the learning disorders or conduct disorders that are primary ECC and mid-childhood into teenagers, that we need to understand what exactly we are treating with when we refer to mental health. We recognize, again, the collaboration that needs to, that we ensure collaboration between the various ministries as well as the Children's Authority, that when we identify our children who are at risk, that there is follow-through, that clearly we cannot continue the referral. We really, we need to detect and screen, and we need to have an understanding within our system and plan effectively, as well as the resource allocation.
Thank you very much, Madam Permanent Secretary. Director, Children's Authority of Trinidad and Tobago.
The Chairman, Hanif Benjamin. We want to take the opportunity to thank this committee for allowing us. From the discussion, it is clear that greater collaboration is a must. We believe that the people sitting in this very room can, in fact, solve the challenges that we are addressing today. There is a great crisis on our hand in terms of placement, adequate placement for our children with mental illness, and we need to come up with an immediate solution for those children. At the Children's Authority, there are a number of children in need of placement today, and we need to collaborate to find a permanent solution to get this addressed. Thank you.
Thank you very much, Children's Authority and President, Trinidad and Tobago Association of Psychologists.
Many of our policies and laws are not fully in line with international human rights instruments. Implementation is often weak, and persons with mental disorders and their family members are frequently marginally involved in their development. The Trinidad and Tobago Association of Psychologists will continue to work with these groups of children and family members. However, let us put into place a mental health action plan for our children and adolescents, because after all, they are the most important asset of our society. Thank you.
Thank you very much, Psychology Association. Yeah, before I continue here, I have come away from this hearing knowing more than I knew before. And the reason we conducted this public inquiry is that we looked at, in the past, the mental illnesses of people in Trinidad and Tobago, and then as we inquired, we found out that children provided a special case. A special case because children, we did a public inquiry prior on bullying in schools. And it came out at that inquiry, it's now on the public record, that bullying can lead to serious mental problems, sometimes even suicide. The curriculum of the school sometimes can, in fact, cause much anxiety. So this is for the Ministry of Education to address, that we do have within the school system itself. Schools can be a stressful place, and we would want to ensure that children are able to cope and to handle the stress. And in that context, I think as first responders, as Madam Permanent Secretary indicated, there is a need for the first responders, the three first responders: social workers, school guidance officers, and the teachers who are on site for the entire day with the children, be trained to monitor and evaluate simply as observers so that they will be able to identify as first responders children who may be having some kind of problems. It was indicated by Dr. Chatur that that is possible. That is a solution. It is possible to catch as many of the children who are at risk as possible. I think that's the interest of the Children's Authority. Let us try to catch as many of the children in need so that we will be able to have early detection and we then provide the necessary treatment as we go along. Once we catch, then we know that the demands will be placed on the Ministry of Health for the professional staff complement as indicated by Dr. Sharp. But we cannot know unless, as Dr. Ramtahal and MP Jennings-Smith indicated, what the numbers are. So all will go back to the Ministry of Education to a large extent to indicate to the general population what they are picking up in the school system and the referrals that they are sending to the health professionals in the Ministry of Health. From the Permanent Secretary and the Chief Medical Officer in the Ministry of Health, it was indicated that by June of 2018, discussions are underway. We have been able to secure many things in this committee by putting timelines. And you will find that you won't get away with this committee when we are vague and nebulous. We want a timeline on things which are reasonable. Things like life certificates and so on for the elderly, we are putting timelines to get rid of them. But with respect to a dedicated ward, I think the professionals, the health professionals, Dr. Maraj and Dr. Sharp and Dr. Chatur and the psychologist Ramtahal have all indicated that children should not be mingling with mental issues, should not be mingling with the adult population. They form a separate and distinct community, and we should be able to treat with them in an environment that is more amenable to their health and well-being. So by June of 18, we expect maybe at the Mount Hope facility, maybe at the Cooper facility, there are many facilities out there. The professionals will determine what is the best site, so we have a dedicated facility for children. People may say 4 beds may not be adequate, but it is 4 more than currently exists. So that let us start and see whether we can have a dedicated facility, since it is accepted that the St. Anne's facilities may not be the best available for the treatment of children. Dr. Sharp has indicated that there really is a need for more professionals. We would need to identify what they are. Knowing that the problem exists, we would need to identify what these professionals are, and we can start the process of manpower planning so that maybe 5 years down the road, it would take maybe in the medical field about 6 years to get a professional on, a specialist on service. So maybe 6 years down the road, we should gradually have the complements that we need. And we know that there is a need for closer collaboration between the Ministry of Health, the Children's Authority, the psychology and the psychiatrists' professions. And once we have that collaboration, maybe this forum might be an ideal way to exchange email addresses so that you will be in contact with what is happening on the ground in the various subunits that you have. And therefore, we will be able to ensure that we share the information to treat. At this point in time, before I close, I would like to advise that the committee's 4th report on an inquiry into the prevalence of sexually transmitted diseases, STDs, among school students and into the general services administered to treat STDs in Trinidad and Tobago will be presented in the House of Representatives this Friday, November the 17th. The report will be available for review on the Parliament's website after it is presented in the House. So out of the deliberations of today's meeting, a report will be presented, tabled in Parliament, and you could be sure that there will be follow-ups with respect to the progress. This morning has been a learning experience for me and committee members, I am sure. It has been one where we are seeing a problem and we are recommending solutions. We can't fix all the problems at one time, but I think there are certain problems which we can fix. Early diagnosis, to my mind, is the first stage in solving this problem. And I leave it to the professionals who are charged with this particular, solving this problem, to handle this issue so that when we have a follow-up meeting, we will be able to issue progress reports on where we are with respect to at least diagnosing and then treating the children of mental illnesses in Trinidad, so that the Parliament of Trinidad and Tobago, while the members are voted by those who are 18 and over, the Parliament will be responsible for those who are 18 and under, and we are sending a message to the next generation that we are here to serve them as well. This meeting is now adjourned. I thank you all for your participation. I thank members of the public, members of the media, and all those who take a keen interest in the deliberation of the work of the committee of this joint committee on social services. I thank you. Good afternoon.